As we embark on this really incredibly important topic, I think one thing we can take light of is that from the first time we did this to now, we have made so much progress. We have so many new options. We have so many new breakthroughs in the breast cancer world that we're very proud of, so that we can really now focus on not only just shrinking tumors and making tumors not come back like I did when I first started, but now also improving quality of life. And frankly, when it comes to Pinkade, there's very few things I will say no to, so that is why I was chosen as the expert to moderate a discussion on sexuality and intimacy. So I will turn now to Dr. Radner, because I am appropriately embarrassed, and say, I read somewhere that 70% of patients report this as a problem, and I probably assume that's understated.
Yeah. Some literature talks about 70%. In our experience that has been published and researched, the numbers are probably closer to 100. It is such a common topic, and I don't want to even say it's a problem. We don't talk about it. It's not a disease. It's not a condition. It is part of the journey. 70%, but really 100% of women who undergo cancer, is particularly breast cancer, particularly gynecologic cancer, experience sexuality, side effects, toxicity, change in life, change in functioning. It affects everybody. And this is why it's so astounding that even though it affects great majority of survivors and women who undergo treatment, it is so poorly addressed. I think what you said is so brilliant. It's actually the whole essence of what I was going to say today. We don't talk about this. It is something that women suffer with. This is something that women live with. We don't talk about it in groups. Physicians do not talk about it. If you humor me, so just Joanna's and my kind of journey with this. So I'm a surgeon. So what I do is surgery for gynecologic cancers. And the reason why Joanna and I founded this, and this is our passion, is that when I graduated and took over a lot of the patients from my mentors at Yale, who are all male. No offense, this is not gonna be good for you.
I'm very in touch with my feminine side.
Yeah, but please brace yourself. I will apologize now, but for the rest of the time. But it's a different. It was a different culture. It was a different approach. I graduated fellowship, became a partner as the only woman. I was the only woman for the longest time. And when I took over a great number of these women from my senior partners, I just was shocked and so touched by this profound lack of care in this area of sexuality and menopause and intimacy. I always talk about this one particular patient who actually started me on this journey, who very frequently actually gave these talks with us when we were starting, this young woman who, as I went into the room as this new attending, my very, very senior mentor said, this patient is our victory. This patient is, our incredible success of our treatment. This patient was in her young 30s. She had cervical cancer. She had radiation. And my leader, my mentors, really very much patted themselves on the back, saying, "Look at me. Look at us. Look what we have done to save this patient." And then I would walk in the room, and this patient was just miserable. She was devastated. Her life at age 33 at the time was ruined. She was divorced for the second time. She couldn't have sex. She couldn't find intimacy. She couldn't find to be with anybody else. And in that very first couple of weeks of my work, when literally I should have been talking to her about chemo, radiation, or surgery, I said to her, how is your sex life? And there was this moment of everybody froze, and then she cried. And I was mortified because I was like, I cannot believe. And she cried so long that it felt like it lasted forever. And she said, I cannot believe that nobody has asked me all these years. At that point, she was 7 years out. She said, for 7 years, I came into this office and I needed to talk about what has happened to me and how my life is destroyed and how I do not know how to keep going. I do not know how to find myself. and I did not know how to bring it up. And I'm so grateful for the care that I got. I just had no opening. Nobody has ever opened the door to have this conversation. And in that moment, and it took us years, in that moment I came out of the office and was like, oh my goodness, like we are forgetting in our strive to treat the cancer, we're forgetting that under the cancer or after the cancer, there's a person, there's a woman who wants to live her life, who wants to have sex and wants to be intimate and wants to find herself and feel herself. And then as Joanna and I established this program and started doing more and more of this care, and this very much became our passion, we found the women who went through breast cancer therapy and treatment, who are breast cancer survivors, suffer from this as much as women with gynecologic cancers, if not more so. This touches everybody. We have published studies, and many national studies have been published, that women with breast cancer and gynecologic cancers, do you remember this study? This was actually a prominent study. 100% of women who were interviewed, and this were hundreds and hundreds of women, felt that this should have been asked. 100% of women felt that they had some sort of a sexuality, intimacy concerns, toxicity, and that 100% of them felt that they should have been asked about it. And out of 1,000 women, I think 900-something women, only 2 women were asked, and only 2 of them were asked by a nurse practitioner. No physician has ever asked any question women with breast cancer and gynecologic cancers about their sexuality, about their intimacy, about menopause, about any of these. And in this big study, it's very similar, I think, to what we feel in our community. Women feel that this was unaddressed and their lives were worse for it. So yeah, 70%, but so much more profound than that.
Yes, so thank you. So I think part of the problem is we didn't ask, both physicians and healthcare professionals. And I think patients were led to believe that they shouldn't ask, which was entirely incorrect, that they should, quote, be happy that they're healthy, which is also absolutely inaccurate. So without getting too technical, and besides the structural things, what are the other issues that we're doing to patients that are making this so much more difficult, the medicines and whatnot? Can you speak a bit to that?
Yeah, I will start, and I think Joanna probably will. So there's so many, for women are such incredibly complex structures. And
now I'm going to take notes.
As you should. As you should. And there's just so much that goes into issues of sexuality and intimacy. It also took us a moment to name our program. Initially it was something very, very different. Then we found that it wasn't just menopause, and it was so much more than just sex. It's so way more than just the act of intercourse and sex. And in the beginning, it took us forever as we trained everybody, and we made our older male physicians just to say clitoris. Even that alone, I feel like was one of the biggest accomplishments. There was a period of time, ladies and Dr. Zakowicz, that we had vibrators. We brought a whole bunch of vibrators, a company. We wrote a grant, and the company couldn't give us money, but they gave us vibrators. So we had a wall of these pink boxes with these tiny little vibrators. And that was before I was the boss and before I even had the office. So we put them in our boss's office, Dr. Schwartz, and he would walk in the room covered, the whole wall was covered by vibrators. And I swear Dr. Schwartz wouldn't go into this office for weeks. For weeks, he did not know how to walk in. And then there was a period of time that we would give everybody a little box. Every little lady would leave our little office with a cute little pink thing, with a huge vibrator. And that alone changed the culture of these conversations.
Yes, I could understand. I gave a lecture at Norwalk in my former life of side effects of aromatase inhibitors, and stood in front of the mirror saying vaginal dryness over and over until my high school son walked by and was trying to figure out what I was doing. So yes, I could relate to that.
Right. So to your point, there's so many structural things. So there's so many physical things. There's so many hormonal things, right? There's simple things like vaginal atrophy. There's simple things that, with age, with menopause, with all the medicines that we give, with aromatase inhibitors, The vaginal mucosa gets atrophic and gets a little bit fragile. But there's so many more than that. Women go through menopause, women who go through menopause early, women who experience hot flashes, difficulty sleeping, cognition, when you feel like you're not as sharp, loss of sex drive. And for women with breast cancer, it is so much more profoundly worse than it is for really anybody else, even for other women with cancer. Because unfortunately, women with breast cancer frequently cannot have the hormonal supplements that usually we can give to try to modify the symptoms. But there's so much more.
So you and I have been talking on the phone for a long time, and we finally met today after years.
Don't date us. Don't date
no, absolutely not.
We are.
And let's just talk about the issue of genitourinary symptoms and how we've evolved from the first conversations we had about vaginal estrogens and to where we are at this point.
That's right. That's right. Exactly. I remember vividly, like probably 2000, actually, like early 2005, 2007. You were one of my very first people who I called trying to lobby for this. I remember the name of the patient to give vaginal estrogen at the time that nobody would. And you and I talked for a long time, and we talked it out. And you said, yeah, we don't usually give it. And I said, yes, but this is who she is, and this is what she needs. And we talked it out, and you said we should give it. So
the basis of that is the first thing they teach you in medical school is do no harm. And so you always want to do things that are not going to be harmful. And so when it came to that, we did not have the data that we have now that vaginal estrogens are likely safe. And they're likely safe for our patients who have had breast cancer. So it's been an evolution that we have gotten better with and become more knowledgeable and I think improved quality of life. Any specific recommendations in that area?
Yeah. So, Joanne and I, the program we started actually was the first in the nation. Nobody at the time in the early 2000s, mid 2000s had any interest or any literature actually to go on. So we were lucky that we have started so early, and now we are lucky that we have so many decades of knowledge and literature, both in our institution, but also nationally and internationally, to know exactly what Dr. Zakowicz just said. Now we know it's safe, and now we know that it is very safe to use vaginal estrogen, even for women on, Dr. Samp will probably talk a bit more about from the breast cancer, but even for women who are in treatment for breast cancer, because it is so localized and gives you benefit really only in the vaginal tissue that we feel that the systemic absorption is so little, and it is safe for women to have. And it has unquestionably changed the landscape of how women feel from the perspective of symptoms of pain with intercourse.
Right.
Joanne and I work with this amazing woman. Her name is Mary Jane Minkin, who is like a riot and amazing. Madame Overy, yeah. And Mary Jane Minkin used to work with Dr. Ruth. So we are like grandchildren, I feel like, of Dr. Ruth, right? So Mary Jane Minkin, and in this day and age, I don't want to be canceled, but we used to say that Dr. Ruth would say, women would be crazy to have sex if it hurts so much, right? Yeah. So we are able to change how women feel about sex really just by this one simple intervention of being able to make intercourse more comfortable. And there's such an easy intervention that can be done very, very safely to improve vaginal atrophy and make intercourse less painful, and through that more pleasurable.
So what I've done as an oncologist is I will typically have the patient see their gynecologist because we want to make sure patients are up to date with their examination. And we have a very frank discussion, and it's all about safety and quality of life. So, good. So, Joanna, where should we go from here? From genital urinary symptoms? I'm flowing, right, Tam? I'm doing good. What color am I?
Yeah. You're doing great.
You're not gonna take stuff out of a bag or anything and embarrass me.
I have a bag of tricks.
Yeah,
I just didn't bring it today.
Yeah.
I didn't bring my bag of tricks. I think it's important to talk about Dr. Ratner's point, the multimodal treatment that's unique to breast cancer. And when we see, in our program, we see patients with any type of cancer. So we see very unique patients who've had a bone marrow transplant for a leukemia, which puts them into menopause early. We see some, kind of rare cancers. Breast cancer is probably our most common diagnosis. And I often do a lot of validation in the clinic and say, you have been hit with so many different types of treatment, and all of them in breast cancer patients impact intimacy. And that's really profound because we have other cancers where, yes, there can be menopause, there can be vaginal dryness, but no other cancer requires a breast surgery, which can impact you right from the beginning. You know, whether your breasts are an erogenous zone for you, if they're important in your sex life, or even in your self-confidence. You know, we see people who come and say, I don't want to take my shirt off in the bedroom anymore. And so sometimes we just start there. So it's breast surgery, and then there's radiation. If the patient has had radiation, that can impact them as far as range of motion, strength, pain, fatigue, skin changes. And then there's chemotherapy. And then there's ovarian suppression. And then there's hormone blocking therapy. And now there's immunotherapy. There are so many different treatments for breast cancer, which is great. And breast cancer is very much survivable now, and people are living long lives and having good quality of life. But we have these young women who've just been hit from every single angle, and every single angle impacts their relationship. Whether it's a relationship with themselves sexually, or with a sexual partner, or with future concerns about dating. And I think that's one of the unique aspects of breast cancer, is just the different ways patients are affected. And I have so many women that come saying, I'm back to work, I have kids to take care of, I look fine, I feel fine. And I say, but you're still on treatment. You know, you're still taking a daily pill that causes symptoms. And the rest of the world may not even see that in you, or know that you're still on treatment that affects you every single day.
Right.
And so I think that's something just to, you know, any survivor here, give yourself a pat on the back for all that you've been through and how it can still affect you, even if you're living a very full and healthy life in a lot of ways.
Yeah, so I totally understand that. So while we're on that topic, what's also gotten a lot of comment these days is systemic estrogens. Mm-hmm. And that's a very touchy subject for the medical oncologist and the surgical oncologist and the team. Anybody want to share some thoughts on where we are with that? That has always been a big black box. It still remains a black box in our recommendations. But there are situations where we are talking to people about hormone replacement therapy.
I'm getting eye contact over here. So. I mean, I have a few thoughts, but I guess a couple things, and maybe Joanna wants to chime in about this. Like, there are different tiers of interventions. So there's sort of over-the-counter stuff, everyday stuff that you have access to right now that maybe we could talk about that, just in case there's anybody in the audience who's like, oh, maybe I want to try that and go buy it right now. And then there's prescription level stuff that's non-hormonal. Again, most of this is for like either GU symptoms of menopause, and sometimes it can help other like sex life, libido, self-esteem, all of that. Then there's the prescription level hormone therapies, mostly intravaginal is what we're talking about so far. But then there's also prescription level systemic hormone therapies. And if you are not on social media, you might not know this, but they are having a moment right now. The FDA took off the black box warning for systemic estrogen and vaginal estrogen. And some people think this was, opening a Pandora's box in a way, because it's up to us now to figure out who benefit from it, who needs it, how we should use it. And again, the influencers out there, if you have anything that's not perfect in your life, it's because your hormones are right. Off balance. So we're, I think, I'm
so glad you went there, because we heard the same thing, where we heard menopause is having its moment. Mm. And there are clearly things that we address and we understand and we respect about menopause. And we also need to understand that there are situations where we need to address that, but it's probably not the answer to all of the issues, and it does need to be a thought-provoked conversation in specific situations.
Right, and so I guess the different tiers should be applied as appropriate, and when is it appropriate for our breast cancer survivors to be on systemic estrogens? We're still triaging and figuring out who it's safe for. And I think you started by saying, our number one mission is do no harm. And for us treating breast cancer, it's that you live a long life without breast cancer. And so we have to be very careful, but we also want to understand that it's a big, complex system that deserves attention, that's why we're here today to talk about
and it's a very cognizant discussion between the doctor and the patient. And shared decision-making and whatnot, and really addressing, and we've come so far, right? Look how far we've come a long way from just vaginal estrogen. So we will continue to evolve, and we will continue to get better, and we'll continue to understand things better. In having you here as the national survivorship expert, yes, she is understated.
Former.
No, she is still,
Interesting.
who's chaired the panel at our meeting. Let's talk about some of the survivorship issues that are also so much a part of patients' lives.
Yeah, so I thank you for that. And I, again, want to recognize that there are so many different ways to approach your patient. I think the number one thing that is sticking to me that I want to make sure I say today is that it's important that you trust your team, that you have a good relationship with your team so that you can talk about these things. And I actually teach the medical students the communication skills so that so we avoid the stories that Elena started with, that the patient had never been asked, right? So what we teach the medical students is to ask the patients, what are your concerns? What are all of your concerns? And to say, what else, so that we can upfront get them all on the table. And I'm trying to tell this to you today so that behind the curtains, like, it's your absolute right to bring in your list.
Right.
And these are all the things, and it's your right to say, wait a minute, I have a few more questions that I would like to be addressed today.
And nobody's a better advocate for you than you. Mm-hmm. So perhaps there is a question that your concern will make the healthcare person uncomfortable, but it's your question.
And again, if you have a good,
question.
trusting relationship, I think, all of us doctors, I want to just say that we get up in the morning to try to help people. We do want that. We're not always the most skilled with how we come across. Mm-hmm. So we're trying to change some of that. But I think having your list and saying it up front, I have like 5 things I really want to make sure, and this is my number one thing, will help everyone. And then the other skill that I really spend a lot of time on is listening. And listening without interruption. And listening with empathy. So believing your patients. Like if you're saying it's so bad, it is bad. Our patients don't come in making things up. So I wanted to just kind of put a plug in for communication and relationship. It's not just in survivorship, it's from the start. And I think that hopefully our tools with AI and all of that will help make this better, not worse. But I do worry a little bit that we might lose some of that in the whole big picture. So it's important to trust your team. In terms of other things in survivorship, I ran a clinic that included a physical therapist, a dietitian, and a social worker. And then we went over all the medical aspects. And our medical part of the visit was the least important because the social worker would talk about fears of recurrence and anxiety and depression and insomnia. The physical therapist would talk about movement and how to get back to where you want to be or maybe even start a new exercise program. And then the dietitian would do the myth busting, right? What can I eat to avoid recurrence? What does sugar feed cancer? What supplements should I take? And so I've become boarded in lifestyle medicine, which is like a really interesting growing subspecialty of medicine that focuses on these pillars of health and what we can do to control our behaviors in order to make ourselves as healthy as possible. And so that's what I think a lot of survivorship and starting at diagnosis moving forward is the definition of survivorship, but really focusing on the choices that we make, the things that we can control, put you in the center of your care. Because there's a lot about cancer you can't control. And you're told when to show up and what needs to happen, what treatments you have to take. But if we spend some time really recognizing there are certain healthy behaviors that can optimize how we handle everything, I think that's where I want to spend a lot of my time.
What's new in the world of nutrition? The GLPs are everywhere. They're all over the news and the media and whatnot. What are your thoughts on the GLP drugs, weight loss, exercise, and whatnot? What I refer to as the WWW, walk, wait, and wine to my patients.
Yeah.
What's the latest on GLPs?
So GLPs are here to stay. And I think that we're going to have to learn how to, again, optimize them, use them the best. The way that they're used right now is for chronic conditions like diabetes and obesity, but we know that we can go to Greenwich Med Spa and get them over the counter right now. No questions asked. So we're going to have to figure out like the best way for that.
Right.
There was a recent study that showed that cancer survivors who took GLPs may have had better outcomes. And it was a large study. It wasn't prospective or randomized. It was just a look. And there's a lot of limitations to that study, but it got a lot of press. They're new, so we
Yeah.
don't really know long-term what...
And we have to
the consequences.
somewhat be a little, we're always encouraged by new things, but we do need randomized studies because sometimes anecdotes can lead us down the wrong path. With that said, I think this is very encouraging.
I think it is. What my worry is they cause a lot of nausea, and then people don't really feel like eating that healthy. And a lot of people exercise just to try to control their weight, and if their weight's really controlled, they don't mind skipping the gym so much. We know that GLP-1s cause muscle wasting, and we're not mandated to prescribe strength
Right.
training with it. Like there's no accountability for what the patients are doing. So if they ever have to come off of this and they've lost not just fat but also muscle, we know the weight gain is all fat. You don't gain back the muscle mass,
Right.
which is, in my world, like sarcopenic obesity is linked to all kinds of terrible cancer outcomes.
Yep.
So I think, again, they're here to stay. We need to learn how to live with them and enjoy them, but remain focused on what is optimizing our health.
Can I
Yeah, but
piggyback off that a little bit? So to go back to the different modalities of treatment for sexual health concerns and menopause symptoms, if a patient, and you probably have a lot of friends who are on hormone therapy and are like, oh, it was a wonder drug, I put the patch on and I feel like $1 million, and you're like, oh man, I can't do that. We still can treat a lot of the menopausal symptoms. We just have to piecemeal it a little bit more. We may say, well, there are some very good new drugs out for hot flashes and night sweats. And thank you to the survivorship guidelines, they're now included in the guidelines for cancer survivors. There are, menopause is having its moment even if people can't take hormones. So we have a lot of new options. And where was I going on that? Oh, the exercise. For the people that I see who can't take hormones, and we talk about, well, let's try this medication for hot flashes because it sounds like those are really bothersome. And let's give you some estrogen cream because you're uncomfortable during sex. Let's get that better. Let's work on the relationship and the communication, whether it's, some, breast discomfort or whether, whatever may be going on in the bedroom. But I always encourage patients to exercise because it helps them feel better about themselves and it gives them energy and it helps them sleep. And if you're sleeping poorly, if you are not working out and you have no energy during the day, you may not really want to have sex because you may be too tired or crabby or just not feel great. So we often bring just the lifestyle aspects into our counseling because it can really help you feel better as a whole and then may help you feel a little bit more confident sexually.
I'm so glad
Does
you
that
went
make
back
sense?
to that because we have now 2 drugs for hot flashes, and one of which we have better safety data and also seems to have some improvement in insomnia, right? So the NTK, well,
And
And
K1.
the
N1
NK3 and NK1 receptor
and
antagonists.
so
Yeah.
while they are very expensive, the preliminary results are that they are safe in the breast cancer population. They are very good for hot flashes, and one of the drugs does have a favorable profile for insomnia. What about new drugs for libido? Are there drugs on the...
Libido is a hard symptom to manage, and we talk about it again in that piecemeal fashion. How is the relationship? How is your anxiety about your cancer? How is your partner's anxiety about your cancer? Because cancer also affects partners for sure. We talk about the physical symptoms. Are you dry? Is it uncomfortable? If it hurts to have sex, like Dr. Ruth said, no crazy person. You'd have to be a crazy person to want to have sex. If it hurts. That's what
pretty good.
It's Dr. Meekin always does the impression. I can't do it as well as she does, but
It's pretty good.
you have to get the patient comfortable. So we try to get you comfortable first. Try to make help you to have positive sexual experiences. So whether that's kind of backing off of vaginal sex for a while and saying, let's work on some gentle stretching of the vaginal tissue. There's something called vaginal dilators that help if you feel tight. We can use estrogen or vaginal moisturizers if you feel dry. So once we fix that, then it's like, I still don't really want it. That's a harder symptom to fix.
Right.
There are some FDA-approved medications for libido. They're mostly recommended for premenopausal patients. They're okay, they're not great. but we can try them. There are about three prescriptions and one over-the-counter medication that we can sometimes talk about for libido.
Can I ask, can you talk about the role of the vibrator in libido?
Do you want to talk about
Because
vibrators?
you
Yeah.
said something once that stuck with me,
Yeah.
and I've told my patients this. If you don't use it, you'll lose it.
Yes, I want to piggyback to something that you said, but we have done studies, hence my story about paying boxes of many vibrators, as we just discussed, that there's unfortunately at times limitations as to what we can offer women, especially women with breast cancer or women who are breast cancer survivors, in terms of hormone management to try to improve their libido. So what has been shown in the literature is that actually it's almost like, the appetite comes during the meal, right? I don't know, it's a little bit of a European proverb, but so essentially the more sex you have, the better the sex that you have, the more sex you would like to have, which kind of makes sense. It's kind of the opposite of, if it hurts, you don't want to have sex, but there's actually more to it. There's some really good studies that showed that having orgasms actually improves libido. So we did studies for women who were not able to have supplementation to be able to increase their sex drive, of using vibrators to encourage women to have orgasms and seeing if their desire to have sex improved. This is a small study, it's anecdotal. In our experience, it certainly has. The women definitely reported that the more orgasms that were productive, that were good, they were enjoyable they had, the more they were actually invested and motivated to have them intercourse with their partners. But to Dr. San's point, there's a lot of literature that says use it or lose it. The more you use it, the more orgasms you have, the more vibrator you use. The more, actually, technically speaking, and I'm not just saying that so he's uncomfortable.
Oh, you've accomplished that already. We started that at that. That was 12:15. I think I'm doing pretty good here.
The more the vaginal mucosa, the more orgasms you have, the more vaginal mucosa actually produces moisture. So there's actually like a practical reason that the more you use the vibrator, the more you're able to achieve orgasm, the better it is for the vaginal tissue, and hence then later on, better it is and easier it is for you to actually have intercourse.
Physiologically, that makes sense.
Physiologically,
Right, that would make sense.
Yeah.
So.
Yeah. I just wanted to piggyback for 1 second, Dr. Zuckman, to your question, what Joanna was saying. And I totally agree with everything you said, and that certain things, of course, are off the table. Systemic therapy is not something that we routinely offer. That being said, we are no longer in the world of, paternalistic medicine.
Right.
Yes, of course, our biggest thing is to do no harm, but it is a partnership. It is not up to me. It is not in my hands what it is right or wrong. For everything now is about personalized medicine and about personalized decisions specifically to you. So I actually very much see my role in this partnership, and I truly see this as a partnership, as giving information and my value is to give you the data and to discuss with you the data and to show you what data I have and what risk you actually have or what benefit you have, both ways. And then together, we make a decision as to what is right for you at that time of your life.
I could not agree with you more.
Yeah.
I think this is all about, nothing is off the table. Yes, our goals, we were trained to try to do no harm. Yes, our goals are to try to communicate. Yes, there are times that the doctor is uncomfortable, and that's on the doctor, not on the patient.
Right.
You need to advocate for yourself,
That's right.
and it's time for joint decision making. And my job is to tell you what the risks and benefits are, and then we make a decision together. And that's every decision you make in life. So I think there should not be any scenario where you can't bring that up. And I think you, again, have got to advocate for yourself because that no one else is going to do that. So that's a great, great point. Nothing is off the table.
Yeah, and you guys, there's a lot of shitty care out there, right? That's the truth. There's a lot of relationships out there that are not relationships, right? There's, Joanna and I not only run this program, we also run another program that has to do with early detection for ovarian cancer. That's our second passion. And there's shitty care there too. There's relationships with patients and providers that are not what you deserve. So I think in every aspect, you have to speak. You're your best advocate. You know, you demand the care that you deserve,
Right.
and if you do not get it there, you turn around and you go somewhere else. You know, here in this state, we're lucky to have so many opportunities. You know, Joanna and I take care of women all over the state, all over the nation. And there's some places where women do not get that. And honestly, I feel like the biggest value that we have is this conversation. You have a right. You are a full partner in this. You are intelligent. You know what is right for you. And if somebody doesn't hear you and somebody doesn't listen to you and you don't get an opportunity to say what you want, or if you feel like you're not being listened to, that is not what you deserve.
You are your own CEO.
You are your own CEO.
Yeah. So,
You know? Yeah.
so is it time for questions, Susan? Is there anything?
Okay.
Is there anything else?
Does anybody have any cards? Well, you start with the,
I will start with whatever you tell me.
I see a hand here.
does he say that to you at home too, Tim?
Not as much.
Pretty much. Everybody here who knows us knows pretty much.
Is this on? Oh, it is. Okay.
No, that's from Carver.
So first of all, I just would love to say thank you to Dr. Minkin and Joanna for saving my sex life. But one of the things that, there's a lot of things I'd like to say and a lot of questions, but I'll just, bone health. We hadn't really talked about that. And, you know, I'm one of those people who complained that my bones were hurting for a long time post-treatment, and it really wasn't discovered until I was really severe osteoporosis. So I'm having Prolia injections, et cetera. You know, we're now being told these HRTs are okay, you know, but so I'm just saying the risk benefit there, you know. I have several unexplained broken bones, and here I am doing, you know, these injections all the time now, so which I would not like to be doing. So if you could just talk about that and what we're doing for bone health, besides just exercise, because also very hard to be motivated to exercise when you're not sleeping and you're exhausted all the time.
So there are a lot of facets to that. So in my practice, we will routinely check bone density in our breast cancer patients. That is standard of care as far as I'm concerned. There are lots of different ways to approach that. There is data about bone health in the patient who has breast cancer, who had breast cancer as a preventive, and there is data about being proactive just for bone health. I tell patients that the bone medications, which can be calcium, vitamin D, or exercise, or Prolia and whatnot, make your bones stronger, but also have an anti-cancer effect. So that should be part and parcel to your health care as a woman, especially as you approach menopause. We do lots of bone densities. So.
I mean, NCCN recognizes this need, and that's our governing body with guidelines. And in the survivorship guideline, it's on our list of algorithms to add. We have like maybe 20 algorithms right now, but bone health has been on our list. We need to partner with our endocrinologists. Not every person has the same risk. Not every person wants the same treatments. Certainly exercise, if you can stay motivated to do it. We know for sure, I mean, there's no question that it helps maintain bone mass during chemotherapy, after chemotherapy, on these medications. And again, it can help with sleep and other quality of life issues, fatigue, things that also interfere with motivation. So if you can sort of get into a good routine, I think strength training has been underappreciated in women. It's coming back up now through Katie Schmitz at the American College of Sports Medicine. It's safe for patients who have lymphedema or are at risk for lymphedema. And it's really a huge element of bone health. So I think if you're going to choose one and you're trying to focus on maintaining your bone mass, I think strength training has been completely undersold and underappreciated in our community.
Yeah, but at the very least, it should be part of routine healthcare for a patient.
Yeah, and I think to your question, Jen, about using hormone therapy, that's again part of this risk-benefit
Right.
discussion. You know, what was your cancer? What did your cancer look like? What was your stage? What was your treatment of cancer? Where are you as far as other comorbid conditions? What does your family history look like as far as cardiac disease? You know, your age, a lot of different factors that go into the very careful decision about hormone therapy. But that certainly can be one of them.
And we talked about so little, you know, we just, because for the sake of time, we mentioned a tiny little sliver of what women experience.
Right.
You know, bone health, heart health, you know, cognition, like that's like so legit, you know. There's women suffer with you know, brain fog, chemo fog, brain fog, menopause fog. Never like that. But Jen, you're absolutely right. And then the bones, which is a huge quality of life thing for women.
Yeah, I feel like I'm lucky I can remember my name these days. But thank you. I think, you know, whatever school comes up with the doctorate of menopause, it's probably going to do quite well.
That's
Right.
true. Some influencer.
There's more training programs in menopause health now, so I think you'll see a lot more, and I know that there might be some in the audience.
And you can certainly look, you can find a menopause.org, you can find a menopause certified gynecologist, and there are some really good ones out there. There are some not so good ones out there as well, so just, you know, vet your choice a little bit if you need some menopause care. They're out there.
And understand that we're also getting educated, and we're also evolving in what we learn and what we know now, which is safe and what's not safe, and what may be overstated and understated. So keep asking, because we're also still learning this. And this, you know, people like Dr. Sampt who are running survivorship, this is so that we can improve all the other aspects of this that we kind of neglected a little bit because we were so focused on one pathway and not realizing how incredibly important this is also. Mm-hmm. Any other questions?
Told you, don't be shy. Okay.
Hi. Okay, Richie, I'm going to say the words vaginal dryness. So,
I practiced.
can you discuss the efficacy of products like Replens or Reverie on vaginal dryness? And also, are there any vitamins or supplements that would also be helpful?
Great question. You know, I took a trip to CVS before another event like this, and I was with my 3-year-old, and we spent $200 on women's sexual health products. And there was like a probably 20-year-old guy checking us out. And I was like, it's for work, don't worry. But believe it or not, you can find, if you are in the women's health aisle these days at your pharmacy, you can find so many products now, including menopause massagers, which are our dilators. They call them menopause massagers. There are vaginal dilators. There are about 1 million different brands of vaginal lubricants, which are used during sex. And there are vaginal moisturizers. So vaginal moisturizers are great. Just like we moisturize our skin and our face, you can use vaginal moisturizers regularly, like for example, every other night before you go to bed. And they come in lots of different formulations. There are hyaluronic acid products like you see with Neutrogena or other types of facial moisturizers. There are, the Replens is one that we've used a long time. That's more of a gel. There are suppositories, lots of different things. For the most part, they're all safe, and it's just a matter of finding what you like. Whether it's a suppository or a gel. Some people need a suppository inside with a little gel around the vulva, because that can get real irritated, or right at the vaginal opening. Or sometimes people alternate moisturizers with the estrogen. If they're prescribed estrogen 2 or 3 nights a week, they use moisturizers on alternating nights. So those are all great. You can shop around, find what works for you.
What about lidocaine?
Vaginal lidocaine is great. It is a prescription, but you think about like lidocaine at the dentist that kind of numbs, but you still feel what's happening. It just doesn't hurt. We often prescribe vaginal lidocaine, and you can ask your gynecologist for this. It's a gel to use right at the opening a few minutes before sex. And some people do really well with that, just to kind of decrease that pain right at the vaginal opening. However, there's usually an underlying dryness or something there that's causing the pain. So we want to fix the dryness first if we can with moisturizers or estrogen cream. But lidocaine can sometimes just help on an as-needed basis, which comes as a prescription.
As far as the specific vaginal estrogens, I've heard different things about the ring and the tablets and the creams. The talk that we both participated in spoke more in favor of the tablets and the ring because it's a more consistent absorption and whatnot.
And the
You're-
smallest absorption.
And the smallest absorption. Right. So that is accurate.
Yeah, I mean, all those options are great, and again, it's very personalized, and some women like the ring, and some women like the cream, very few women like the cream, and the suppositories are really good because they're more convenient, they don't leak as much, so it's not as messy, and yes, you know, it's in our time that the dose has decreased substantially. When we started using it, it was like
Right.
2.5 times more, and then studies were done that a much smaller dose was sufficient to be able to provide atrophy relief at a smaller systemic dose. So we tend to recommend the suppository from the perspective of a smaller dose, more convenience. But then, so exactly to Joanna's point, sometimes the suppository alone is not sufficient because the suppository goes deep inside and kind of, you know, moisturizes the vagina high up. But very frequently, in addition, we recommend a little bit of estrogen, right, like to the first knuckle on the outside, right at the insertion site. Because when women have pain with intercourse, some women have deep pain, and the suppository will help with that. But a lot of women have pain literally at the opening. You know, it has to do with like development and where the most estrogenized tissues are. The most estrogenized tissues in the vagina are actually right by the introitus where you enter and right below the urethra. That's why women who go into menopause very frequently feel like they have a UTI, because it's the lack of hormones, the lack of estrogen that makes them, and where they feel it the most is right under the urethra, and that's why they feel like they have UTIs and keep like getting antibiotics and then nothing keeps growing. That is not an infection. That is really from the menopause and from the atrophy in the tissue, and right outside of the introitus where you enter, and that's why you need a little supplement there.
So if you are having that symptom of urinary frequency, it's not really an infection, do you prefer the paste then in order to put it in that localized spot?
Yeah, we usually start a little bit with the cream, and then like you just need like a nice boost, and then after that you can go to the suppository.
Got it.
Yeah.
And sometimes it's trial and error. What works best for one person doesn't always work best for somebody else.
There's also like guys, a lot of like people out there, like people recommend like tons of cream, like a pound of cream in the vagina. You do not need a pound of cream, right? Like frequently we see on when women prescribe it, they prescribe like 2 grams. Like you actually do not need that much. You know, you need a much smaller dose. I think that's where like this personalized approach comes in. You know, that you do not need much. You need a little bit in the right way, in the right place, at the right time. You know, again, officially things are prescribed every single night. We found that you don't need to do it every other. You know, we do it every other night for a couple of weeks, and then you probably can get away with once or twice a week. Like everything is very, very personalized, and you need to be with somebody who's very experienced, who knows, especially for you with your history, what is the least that you need to take care of the symptoms.
Right.
One thing I have to give Dr. Ratner credit for is, from the beginning of the SIMS program, we've included psychologists because they're really, really helpful in just helping to manage whether it's some trauma, some relationship challenges, some communication barriers, the sleep issues. So we have psychologists on our team. And I've learned a lot from the psychologists over time. And one thing we sometimes talk about is just kind of managing our expectations about sexual health. And so we sometimes say, if you haven't been sexually active or you haven't had penetration sex in a long time because you were on chemo, because you were recovering from surgery, whatever the reason, there's a lot of anxiety and pressure about that first sexual encounter. You know, the longer you go without, and then it becomes this awkward, is it going to hurt? Am I going to hurt her? Is it going to be fun? Are we going to have an orgasm? And then it just becomes this whole anxiety, and then everybody gets disappointed. So I think it's just managing our expectations and saying, having that communication if you have a partner and saying, I'm working with my body, I'm working with my treatment, a lot of this is because of the therapy that I'm on. It's not that I don't desire you, it's not that I don't want to be intimate with you. There can be a lot of just challenging feelings on both parties. And so we have so many patients that come to our clinic and say, I feel really guilty for my partner. And I said, well, I hope that your partner also feels guilty that you've had cancer. It's like, it's okay to feel like this is unfortunate because of what's happened to us, and work with our partner to talk about it and say we still care for each other, we still want to have intimacy. We just need to figure out how it's going to look for us. And how it looks right now may not be how it's going to look in a few years. It can get better. But we're just working with each other and being open and caring to each other. It's really important.